Sir, it is live.
So, a very, very good afternoon from on the behalf of Endocrine Society of India. So, we are going to have a very, very interesting talk today afternoon, and it's going to be on voice and endocrinology. So, it's an intriguing topic. So, people might think, what is the speaker going to talk on? And I always felt I had a bad voice, and when I listened to Dr. Kalra, who happened to be the past president of ESI, and even Dr. Ganpati, who is the current president of ESI, I always felt how they have good voices. So, is there something behind the voice and the endocrine link and the hormonal link? So, we for that we have two very interesting sessions. So, one will be quiz and followed by a lecture, and we have none other than Dr. Kalpana Nagpal, who is a renowned ENT surgeon. She is working in Apollo Hospital, Sarita Vihar. She did her MS in ENT from AFMC. She's also a DNB from the National Board. She is the chief of robotic surgery, head and neck in Apollo Hospital, Sarita Vihar. And she has multiple publications. She is affiliated to multiple organizations. I now hand over the proceedings to Dr. Kalpana for carrying it forward. Over to you, ma'am. Ma'am, you are muted.
Yes.
Yeah.
Thank you, Saptarishi and other organizers. It's indeed a very interesting topic for today afternoon, voice and endocrinology. Well, it's also a vast subject. It can take us, many days because there are several chapters on it, and there are voice clinics all over in India as well as in the world. And it is a very super specialized branch, just the voice. And there are medical disorders and surgical disorders. So you have voice clinics as well as phonosurgery clinics. And there could be physiological disorders affecting the voice, and there could be, structural disorders or functional disorders, which means pathological disorders also affecting the voice. And as a surgeon, like for me, voice is so important because we do thyroid surgeries and parathyroid surgeries now, more so with the advent of robotics. With the advantage of giving good cosmesis, there's no scar visible in the neck, but yet sparing the recurrent laryngeal nerve and superior laryngeal nerve is very, very important because post-operative, this is the first thing we look for, any change in the voice. So there are innumerable patients walking in every day, and most of them go to endocrinology clinics. If there is a voice change, they would like to know if there's any, is it due to hormonal change or is it due to any other reason? And the endocrinologist, depending upon the need, I mean, if it's a medical thing, most of them manage. And if they suspect something in the voice box, then they do give us references for ENT evaluation. And now the abnormalities could be in the vocal cords related, like there could be a lesion there could be polyps, or there could be any other mass. And there could be any other, a mass lesion like thyroid or any other parathyroid adenoma, or it can be anything which is in and around the laryngeal framework. So they can be disorders which are related to the laryngeal framework or extralaryngeal muscles, or it could be the recurrent laryngeal and superior laryngeal nerve. So it's innumerable. I mean, sometimes both the nerves may be normal, and yet there could be a voice disorder. That's because, like in endocrinal disorders like hypothyroidism, there could be some accumulation of polysaccharides. And so it goes on and on. So there could be various endocrine disorders causing voice disorders. And that is why today we have two interesting sessions. And we would be discussing all this in detail. And towards the end, we'll have a question answer session as well. So we have, in order for you not to get bored, actually, there is a quiz session which starts in the beginning. And so it's all exciting. You guys should answer it well, think properly, and the people who answer well will be awarded a prize at the end. And so all the answers will be announced at the end of the session. So be ready with your quiz. Now, before we start the quiz, I'll be introducing the quiz master. Quiz master is actually none other than Dr. Spurti Pai, and she's done both her MBBS and MD from Bangalore Medical College. And she's done her DM in endocrinology from the prestigious institute, St. John's. St. John's has been very popular, all of you know, and they have a lot of walk-in endocrinology cases in other cases. And she also received the best going student award for her batch in 2014. and many other accolades. Like she's been a rank holder in MD in 2017, and she was the university topper in 2020 for DM. So here we welcome Dr. Spurti Pak. And so she would begin with the quiz. So all of you get ready to watch.
Good evening, everyone. So I'll be starting with a quiz. And good evening, respected ma'am, Kalpana ma'am, and all my colleagues, my friends and juniors who have joined this session. I hope this quiz is exciting enough. So I'll be sharing my screen, and so let's begin the quiz. So initially, I will be displaying all the questions. That there are 10 questions and one audience question in this quiz, and the answers you will have to type all together. That is at the end of all 10 questions, and you will have to type the answers in the chat box. And the answers, all 10 questions, you will be answering. For example, if the answer is A, 1A, 2B, 3C, etc. So please do not type the entire answer. Type the question number and only the option number. So if any clarifications, you can ask it in the chat box. So please type it at the end of the 10 questions. So question number 1. In pubertal boys, the largest changes in singing and speaking frequencies occur between which gonadal stages? A. Tanner stage 1 and 2, B. Tanner stage 2 and 3, C. Tanner stage 3 and 4, D. Tanner stage 4 and 5. So coming to question number 2, the total length of the vocal cords in an adult male is A. 12 to 15 millimeters, B. 7 to 8 millimeters, C. 13 to 18 millimeters, D. 18 to 23 millimeters. Let's move on to the third question. So you can see the pictures here. So you relate the images and identify this condition and the voice associated with this condition. So A, high-pitched voice, B, hoarse voice, C, deep sonorous voice, D, no change in voice. Moving on to the fourth question. Arytenoid cartilage dislocation could be a complication of which of the following? You can see in the pictures, they display arytenoid cartilage dislocation. So the options are A, chronic steroid use, B, acromegaly, C, diabetes mellitus, D, all of the above. Coming to question number 5, again you have pictures on the right side. So identify the condition, and hoarseness of the voice in this condition is due to A, mucopolysaccharide and fluid accumulation in the vocal cords, myedema of the cricothyroid muscle, neural edema of the vagus nerve, D, all of the above. question number 6. The most common site of recurrent laryngeal nerve injury during thyroid or parathyroid surgery is A. Intralaryngeal portion of the recurrent laryngeal nerve, final 2 centimeters of the extralaryngeal recurrent laryngeal nerve before entering the larynx, C. Around the arch of aorta, D. Around the subclavian artery. The most common site for recurrent laryngeal nerve injury during the thyroid or parathyroid surgery. So question number 7. High-pitched voice is seen in which of the following individuals compared to their healthy counterparts of the same age group? A. Untreated Turner syndrome. B. Congenital adrenal hyperplasia. C. Male to female transgender patients who are only on medical management. D. Growth hormone excess. High-pitched voice. So question number 8 is a case scenario. A 28-year-old female singer with no other comorbidities presented with inability to sing high notes during the few days prior to her menstrual periods. So she also complained of low mood and abdominal bloating during those days. What do you think her condition is? A. Psychogenic dysphonia. B. Spasmodic dysphonia. C. Recurrent laryngitis. D. Dysphonia premenstrualis. Question number 9. Which of the following is caused by the effect of progesterone on the vocal cords? A. Lengthening of the vocal cords. Increased secretion of the laryngeal glands. That's option B. Option C. Dryness and reduced tonicity of the vocal cords. D. Atrophy of the laryngeal muscles. Question number 10. Menopause in women can lead to A. Decreased pitch of the voice. B. Increased pitch of the voice. C. No change in the pitch of the voice. D. Either of the above. So these are the 10 questions. I have another audience question. So this is for the general public. Can you relate the images? Can you identify the personality and what was he known as? So you can see there are 3 images. There's a connection with all the 3 images. Can you identify this? So that comes to the end of the quiz. So you can all type the answers now, and please type only the question number and the answer option, that is A, B, C, or D. Thank you.
So I hope all of you are sending your answers in your private chat box. Congratulations, Purti, for this well-defined quiz. Excellent job done.
Thank you, ma'am.
Let us give them 5 more minutes.
Yeah, we can, in the meantime, we can invite Dr. Nandini for the chat also.
Okay. So now we have a speaker, and for basically she's going to talk on this main subject for today, voice and endocrinology. So Dr. Nandini Perumal is the speaker. Now she's done her MD Pediatrics followed by DM in endocrinology. And she's also a clinical research fellow from Royal Manchester Hospital, Children's Hospital in UK. So let us welcome the speaker, Dr. Nandini Perumal.
Hello. Hello, everybody. I would like to thank the Endocrine Society of India and the organizers for this opportunity.
So if all of you are done with the quiz, we can start with this session.
We can start with the session.
Right. Over to you, Dr. Nandini.
So a very good evening to all the participants and the organizers. I would like to thank the organizers for giving me this opportunity. It's a very interesting topic, a rather unheard topic, forgive the pun. So I really enjoyed preparing for this topic, and it made me look at voice in a different light, a different perspective, because we never give a second thought to voice. So if you think about it, voice is one's identity. Your vocal print is like your fingerprint. It's very unique. And when you hear somebody's voice, you can immediately recognize them. And even if you've never met a person, so when you listen to a voice, you can make an educated guess about their gender, their age, and from the way they speak, how educated they are and where they are from. So you can gather a lot of information from one's voice. And many of us make a living out of our voices. So what is voice? It's nothing but it's sound that is produced by the vocal instrument. And like any instrument, a musical instrument, you need a power source which pushes the air across a vibrating body, and that is further modified in a resonating chamber. So this is how sound is produced. So here the respiratory power source are the lungs, our chest muscles and the diaphragm, which push the air across the vibrating body, which is the vocal cord, which is further modified by the oral cavity, the nasal cavity, and when we speak, we modify it further with our lips and tongue and teeth. So that is how we produce voice or speech. So speech or voice has several interesting characters. The one that all of us can instantly identify, and the most important one, is the pitch of the voice, which is determined by the fundamental frequency at which the vibrations happen. So males have a deeper, low-pitched voice, when females have a higher, high-pitched voice with a frequency of about 190 to 220 hertz. And there's a range in between where it is gender ambiguous. This is important for us to remember, because later we'll see that when we're dealing with patients who are undergoing gender transformation, this is very important. So why is that males and females have different voice pitches? One would wonder. So this is called sexual dimorphism, and voice is a highly sexually dimorphic feature, especially in humans. So if you think about it, nature has one agenda for all of us, for all species, that is to reproduce. And unfortunately, it's a little unfair on the males, and because the onus of successful reproduction falls on the males of the species. So they need to have some trait to woo the female of the species. If you look at birds, they have really colorful feathers, they dance and sing and woo the female. In primates, it's the voice. So studies of evolution show that in primates, having a deep voice in a male provided a distinctive reproductive advantage and ensured successful reproduction. So it's not surprising that this trait has been selected and has been developed over centuries. And now, as humans, we are one of the highly sexually dimorphic when it comes to voice. In fact, voice, even today, plays a very important role in our social lives, because people with deeper voices, both men and women, are perceived to have higher social power in terms of leadership abilities. They are perceived as more capable and more dominant. So voice affects us even today in our social lives. So how does this difference happen in voice? And it all comes down to our gonads, our testosterone synthesis. So estrogen and progesterone also have an influence on voice, but it is not as dramatic as that of testosterone. So during puberty, when there's a surge in testosterone levels, the whole vocal apparatus undergoes a series of changes. So the vocal cords increase in length, they become thicker and wider, but they remain lax. The muscles hypertrophy, the mucosa thickens, and the thyroid cartilage develops the characteristic Adam's apple by becoming narrower. The cricothyroid membrane widens and the corresponding muscles also become more powerful. With this, we have the strengthening of the chest muscles, which gives the force and power to push the air through the larynx. So all these changes put together result in cracking of the voice, and the voice becomes deeper and they're unable to achieve a higher octaves. So this is called the cracking of voice, which is a highly significant event in the secondary sexual character development in males, and it is considered an equivalent of menarche in women. It's very important here to remember that the changes introduced by testosterone is irreversible. This is very important because in women who have been exposed to androgens and in males when they're transforming to females, these changes are permanent and hence we need to be very careful when dealing with them. So the permanency of these effects, interestingly, were observed several centuries ago. And in Italy, like the last picture that Dr. Spurti showed you in the quiz. So the Catholic Church did not allow women to be a part of their choir, but they still liked the feminine voice to be a part of the choir. So what they would do is they would castrate young boys with exceptional musical qualities in order to preserve the high-pitched prepubertal voice. So what happens in women during puberty? They also undergo a few changes under the influence of estrogen and progesterone, but it is not as dramatic as that of testosterone. So the vocal muscle thickens very slightly, but it remains very supple and elastic, but there is little development of the cartilage or the membrane. So this results in a slight drop in the pitch when compared to the prepubertal levels. But the mucosa is still dependent on hormones. So that is why women can develop a premenstrual vocal syndrome, where there is voice fatigue, a reduction in the range of the pitch, loss of power, and especially noticeable in singers where they cannot achieve high pitches and they cannot sing properly a few days before their menstruation. So an examination of the vocal cord at this time will show there is congestion, varices, and edema of the vocal cords. During menopause, there is a reduction in the level of estrogen and a relative increase in the levels of androgens, which can again lower voice intensity, cause voice fatigue, and reduce the range of voice pitch and loss of vocal quality. So this is due to vocal muscle atrophy and reduction in thickness of the mucosa, and also reduced mobility of the joints of the throat. Interestingly, hormone replacement therapy can improve these vocal symptoms in postmenopausal women. In children with Turner syndrome, because they are short, they have a smaller larynx, and some of them have partial androgen insufficiency. So they tend to have a really high-pitched voice at presentation. So treatment with growth hormone, because later we would see that growth hormone influences the development of the maxilla and the mandible. So that, along with oxandrolone, which is an anabolic steroid, which is not very often used, but sometimes in the West they do. It's often combined with growth hormone to promote height. So these children, when they receive oxandrolone, can notice a deepening of voice, it happens in a dose-dependent manner. The other group of conditions where voice becomes important is when we are dealing with a woman with signs of androgenization. So patients come to us with hirsutism, increased body hair growth, facial hair growth. But what distinguishes it? what tells us that this is something very sinister and serious is a voice change. Because you need to have a threshold level of androgen, usually more than 200 nanograms per dl, with a significant duration of exposure for your voice to change. So when a woman presents with signs of androgenization and there is a voice change, that should tell you that this is something sinister, this is something serious, far more than this is not just simple PCOS. So that is when we should look for serious causes like tumors and CAH. So we are increasingly seeing patients who want to undergo gender reassignment, and voice is a very important part of gender reassignment because voice is our identity. And when we transform, when we reassign them to a different gender, their voice has to be gender congruent. So the treatment, what we give, mainly focuses on modifying pitch, but pitch is just one aspect of voice. So what we should remember is that we can modify the pitch of the voice, but that does not guarantee gender congruence. So here we should remember that should be successful behavioral therapy and voice therapy so that they can modify their airflow, modify their voice, and because they need to change their intensity, the intonation, the resonance. There are so many other features of voice that tells us whether it's masculine or feminine. So interestingly, a lot of these patients, even after hormonal interventions or surgeries, fail something called a telephone test. What's a telephone test? You talk to somebody over a telephone and they have to identify the gender of the person, because you're taking away all the other cues that will help you in determining gender. So many times, even if the pitch range that is needed is achieved, many of these patients fail a telephone test because the other features give away, like the intonation, their intensity. So a feminine voice is supposed to be less loud and they have a greater pitch variability, but a masculine voice is supposed to be more monotonous. They have a less range in pitch and they're generally louder. So these are certain aspects that we should remember when treating patients who are undergoing gender reassignment. So female to male gender reassignment in terms of voice management is definitely easier because you have a good response with testosterone treatment. The voice deepening happens soon after initiating therapy, and maximum voice change happens during the first year, and subsequently there isn't much change. But by the end of 1 year, the voice is very comparable to that of biological males. And testosterone alone can reduce your fundamental frequency, that's the pitch of the voice, by 70 hertz. And this would bring it within the gender ambiguous range that we talked about earlier, which is what we are hoping to achieve. So the response to androgens is not uniform in all of these women. And there is a correlation with the number of these CAG repeats in the androgen receptor, which will determine the androgen sensitivity. So if there is reduced androgen sensitivity, there may not be a very dramatic or as a change that we would expect. So they can still have some problems with voice and pitch. This is where voice therapy becomes very, very important. Very, very rarely, they would require surgeries where a type 3 thyroplasty, where the thyroid cartilage is removed. This will then relax the vocal cord and produce the pitch. Voice modification in male transforming to a female gender is definitely a lot trickier because, as we saw, the changes due to testosterone are often permanent and cannot be reversed. So when we replace or give them estrogens with HRT, they do not develop significant female voice. However, how they perceive their voice, that is the self-perception of voice, surprisingly improves with HRT. This is because of the other biological changes that happens with HRT. So they are able to say, since there are biological changes, they perceive themselves as more feminine. So their perception about voice also improves. So it is advisable to give HRT for a few months, for at least 6 months, before invasive voice intervention is considered. Voice therapy, again, is very, very important because they can change the resonance of the voice by just moving their tongue. Like simple maneuvers are taught where they can move, reduce the space within the oral cavity, and they can adjust the voice that is produced. Phonosurgery, or the surgical management, becomes an important part of treatment here. So historically, earlier, the surgery involved altering the structure of the larynx. So you are suturing the thyroid cartilage to the cricoid cartilage to increase the tension. You are basically modifying the structure of the larynx. So today it is not as invasive. There are endoscopic approaches. A few endoscopic approaches that are used are where the epithelium of the anterior third of the cord is removed, and you apply something called the voice shell, which will result in the formation of a web and reduces the length of the vocal cord. So we have carbon dioxide laser, which is being used to reduce the mass of the vocal cords so they become thinner and lighter. There's a surgical procedure called glottoplasty, where the vocal cords are sutured and hence the length is shortened. As we said earlier, many of them fail the telephone test postoperatively, even though the results of the surgery per se are successful. So this emphasizes the need for continuing voice therapy. So these are some of the pictures that show of the glottoplasty procedure itself. In B here, we can see that the epithelium is denuded and some sutures are put in. And postoperatively, you can see a reduction in the size of the vocal cord from the preoperative size in panel A. So the gonadal hormones, no doubt, have profound effects on voice, and in various disorders, voice is affected. The other hormone that can influence voice is growth hormone, because it affects craniofacial development. And the pitch of your voice correlates with the size of the maxilla and the mandible, and to some amount the soft tissues. So growth hormone can affect the size of maxilla and mandible, And we often see that children with very severe growth hormone deficiency have mid-phase hyperplasia. So they have very high-pitched voice, which is seen in both genders, and it is present across lifespan, especially when they are not treated. What happens in growth hormone excess? So there is an overgrowth of the bone, overgrowth of the soft tissue component of the throat. There is thickening of the vocal cords. The laryngeal mucosa becomes very lax, and can also have problems with the cartilage and the joint. And there is arytenoid cartilage dislocation, which is very commonly seen in these patients and a few other endocrinological conditions. So all of these changes, along with the expansion of the sinuses, we saw that the sinuses in the nasal cavity can modify voice. So all of these changes put together will result in a lower pitch, hoarse, sonorous voice in acromegaly. So most of these treatment, especially the edema and the hypertrophy part, tends to reduce with surgery and medical management, and it can reduce the voice handicap that these patients have. We all know about thyroid and how hypothyroidism can cause hoarseness of voice. And I think we've been hearing that from our undergraduate days. Yeah. So there is a lot of deposition of mucopolysaccharide all over the body, especially in the vocal cords, which tends to retain water. And so there is edema of the cords, edema of the cricothyroid muscles and the vagus nerve also, which can result in hoarseness, low voice, reduced range, and voice fatigue. A less common cause of voice change that is related to endocrinology would be hyperthyroidism, which can also cause hoarseness of voice and can produce trembling of voice, and you can even lose your voice, or aphonia has been reported with hyperthyroidism. Like Dr. I had introduced at the beginning of the topic. So patients who are undergoing thyroid or parathyroid surgeries, voice is a very important issue. It can have medical legal consequences also. So it is routinely attributed to recurrent laryngeal nerve palsy. However, not all patients have recurrent laryngeal palsy. They can have an injury to the superior laryngeal nerve, which is the tensor of the vocal cord. So when that is injured, they cannot reach higher pitch. So they cannot shout, they cannot sing high pitches. So it is not always due to recurrent laryngeal nerve palsy. And there are less other causes of voice change as well, which is can be a damage to the superior laryngeal nerve, which is not often recognized. It can just be a result of the intubation. It can be due to the stretching of the strap muscles, which happens during surgery, or it can be due to the laryngeal venous drainage, which is altered during the surgery. So this means that there are other reasons for voice change. The good news is that less than 10% of them are permanent. And not everybody has recurrent laryngeal nerve palsy. Not all patients with recurrent laryngeal nerve palsy have voice change. It's very important to assess the right etiology and to reassure the patient, because most often it resolves on its own. So neuromonitoring intraoperatively will help in identifying and isolating these nerves and can greatly reduce the risk of voice damage that can happen with surgical procedures. So I hope I have summarized all of the endocrine causes and how our hormones can influence one's voice in health and sickness. It was a very interesting topic for me, and I believe that because voice is one's identity, it tells us a lot about a person. It's very important for us as endocrinologists to recognize the importance of voice, identify how voice can be affected in various endocrinological problems, and try and fix it, involve our colleagues and friends, take the help of voice therapy and our ENT colleagues to fix complex situations. Thank you so much.
So thank you, Nandini. That was a very lucid presentation. You have covered everything more or less. And I'm sure the audience has enjoyed. You made it very simple and elaborate. So congratulations.
Thank you.
So now we move on to the question answer session. Dr. Saptarshi, is that the order now next?
I think if you have any queries or your inputs, ma'am, you can just suggest that.
Right. So now basically the audience has to understand that there are various aspects to this. Well, the importance of voice, Nandini has already discussed. And similarly, voice has several, how do you, there's a need for me to mention stroboscopy. Now, what is stroboscopy? Basically, this is to study the vibrations of the vocal cords. So all over where people run voice clinics, they do have stroboscopes. And so patients who are professional voice seekers, they want to manipulate their voice according to the profession. And so they actually look for these professional voice surgeons like phonosurgeons. And those clinics where these stroboscopies are performed, you'll be amazed to see the pitch and frequency that varies from person to person. And that's how, even very fine tuning of this is required. And a super specialization for this, there are various clinics that are in UK, where you get short-term fellowships. Even for a week also, people can go and observe and learn. But there are long-term fellowships where you can actually super specialize in this subject. And so for juniors, it is a very interesting field. So laryngology, as if one wants to take up, there are bigger surgeries like laryngeal transplant happening. But for day-to-day, I mean, if you really want to make a good earning for your life, you can choose this also as one of the professions. Now, being a robotic surgeon, I would also like to give and make you understand, that is why the advent of robotics for today. One is we're not giving any external scar in front of the neck. So we're doing either transaxillary or retroauricular. approach for the thyroid surgery so that the person doesn't have a visible scar. But there are other advantages also. So since the surgeon has 10 times the vision and a 3D vision, now because of the 10 times magnification, it is practically impossible to go and knock off these nerves. Even for a traditional surgeon, it's important to understand the anatomy. Even though you have those nerve monitors, etc., one has to be perfect with anatomy because the neuromonitor can signal even if you're a little away from the nerve. So intricate anatomy details and precise dissection is important. And somebody who's interested in learning robotic surgery or somebody who wants to observe thyroid surgery and understand the steps, robotics is a good way of learning. The learning curve in this is better because as an intern, when I was an intern, I still remember when my senior surgeon was performing a subtotal thyroidectomy, we were a bunch of 30 and we were all watching, and he would excitedly say, well, this is the recurrent laryngeal now. Now, honestly tell me, how many of you actually see it? In a traditional surgery, other than the surgeon and the primary assistant, nobody else can actually see those steps or anatomy. It's practically difficult. And imagine a group of 30 where how many would, other than taking home the theoretical message, you're not really getting trained well in those surgical steps. Whereas in robotic theater, we have a 2D screen where the other surgeons and assistants, etc., can watch, and each and every step is demonstrated by the primary surgeon who's sitting on the 3D console. So the learning curve is much faster. Now, similarly, voice disorders run by endocrinologists, they're doing a great job. Now, a lot of pubophonias come to us, and pubophonias we refer to the endocrinologist, and similarly, they do refer us if there is any, for example, a thyroid tumor can present with hoarseness because of directly infiltrating the nerve, or it can be because of compression. Now, there are various specialties actually dealing with voice, apart from pediatricians and general physicians, endocrinologists, ENT, and speech therapists, as well as neurologists, psychiatrists. So it goes on. Sometimes there are patients who have been to 4 different clinics, 4 different specialties, and not got a solution yet. Because identifying the cause for the voice disorder may not be that easy. So it's a huge challenge. So voice and endocrinology, as it seems easy, it's the toughest subject, both to treat medically and surgically. Similarly, thyroplasty surgeries, they're not easy. There are different types of thyroplasties, and most of them are performed under local anesthesia because you want to assess immediately after doing the surgery. You want to listen to the patient's voice and listen to the previous recording and compare, and more or less it's very difficult to give him back the exact same normal voice. So I leave it to the audience now for further questions and answers. I hope all of you enjoyed today's session.
I will now request Dr. Spurti to discuss the answers to the questions and also discuss the announce the quiz winners, please.
Hello again. I'll be discussing the answers now. As you know, Dr. Nandini has covered almost all the topics which were covered in the quiz. So you would have got the answers by now. And even Dr. Kalpana ma'am has also given us very nice inputs regarding voice. So I'll start sharing the answers now. So coming to question number 1, which was in pubertal boys, the largest change in singing and speaking frequencies occur between which gonadal stages? So the options were between stage 1 and 2, stage 2 and 3, 3 and 4, and 4 and 5. So the answer to this question is Tanner stage, between Tanner stage 3 and 4. This approximately occurs at around 13 years of age when the voice breaks. This is because of the lengthening and thickening of the vocal folds. Adam's apple develops, and also there is strengthening of the laryngeal muscles. This has already been discussed. And cracking of the voice in boys is considered as a milestone, which is similar to the attainment of menarche in girls. So coming to question number 2, the total length of the vocal cords in an adult male is, options were 12 to 15 millimeters, 7 to 8 millimeters, 13 to 18 millimeters, and 18 to 23 millimeters. So the answer is option D, 18 to 23 millimeters. So the vocal cords of the adult male are the longest. So 12 to 15 millimeters are the prepubertal vocal cords, whereas 7 to 8 millimeters is the membranous part of the vocal cord, and 13 to 18 millimeters is the length of the vocal cords in an adult female, and 18 to 23 millimeters is in adult male. So answer is option D. So coming to question number 3. So this is an image-based question. So identify the condition and the voice associated with the condition. Options were high-pitched voice, hoarse voice, deep sonorous voice, and no change in voice. So as you can see, these pictures, the first picture displays a pituitary macroadenoma, which you can see it is occupying the sella and the suprasellar region. The second picture shows there are enlarged sinuses in this picture. You can see there is a very prominent frontal sinus, and also the maxillary sinus has enlarged. And also if you observe, the skull has thickened, the calvarium. So this indicates enlarged sinuses and hypertrophy. And the last picture demonstrates the spade phalanx sign, where the terminal phalanx, you can see a spade-like thickening is present. So the condition you can identify, all of you, that is acromegaly, and it is associated with the deep sonorous voice. So it's both because of the soft tissue enlargement, also because of the enlarged sinuses, which causes a sonorous nature. Coming to question number 4, the arytenoid cartilage dislocation could be a complication of which of the following? A, chronic steroid use, B, acromegaly, C, diabetes mellitus, and D, all of the above. And the pictures demonstrate the same. So this is during laryngoscopy. The below one shows during laryngoscopy, and the upper picture is from the CT. So the answer is all of the above. So all these conditions lead to a degenerative arthritis of the cricoarytenoid joints, and this can lead to a arytenoid dislocation. So most commonly, this is precipitated by intubation, which happens during the surgery, during the general anesthesia. So because of the medialization of the vocal cords, this can also be mistaken for recurrent laryngeal nerve palsy. Coming to question number 5. So again, picture based. So you can see the pictures. That is classical myxedema. So identify the condition, that is myxedema. Hoarseness of the voice in this condition is due to what? A, mucopolysaccharide and fluid accumulation in the vocal folds, myedema of the cricothyroid muscle, neural edema of the vagus nerve, D, all of the above. So the answer is all of the above. So you can see the myxedematous species and the non-pitting pedal edema in the pictures. Question number 6. The most common site of recurrent laryngeal nerve injury during thyroid or parathyroid surgery is A, intralaryngeal portion of the recurrent laryngeal nerve, final 2 centimeters of the extralaryngeal recurrent laryngeal nerve before entering the larynx, around the arch of aorta, around the subclavian artery. So as you can see, the course of the recurrent laryngeal nerve, it comes from the vagus. So the vagus goes down, and as it goes below, it has a different course on the left side and the right side. So on the left side, it winds around the arch of aorta, and on the right side, it winds around the subclavian artery. So then it travels through the tracheoesophageal groove on both the sides and approaches the thyroid near its lower pole. So near this lower pole of the thyroid, it can be next to the arterial bundle, and during the surgery, there is a possibility that it can be ligated along with the blood vessels. That is just before entering the larynx, the final 2 centimeters of the extra laryngeal recurrent laryngeal nerve is the most commonly damaged portion. Question number 7. High-pitched voice is seen in the following individuals compared to their healthy counterparts of the same age groups. As Dr. Nandini has already discussed about these conditions. So options were untreated Turner syndrome, congenital adrenal hyperplasia, male to female transgender patients on medical management, growth hormone excess. So the answer is untreated Turner syndrome. So as they are short, they have a shorter vocal cords, hence the higher pitch. And in congenital adrenal hyperplasia, virilization can occur, which can lead to a lower pitched voice. Male to female transgender patients, the vocal cords cannot be shortened with medical therapy. Hence, the pitch doesn't change drastically. It's only their perception can change with hormonal replacement therapy, as ma'am had explained. And growth hormone excess, as we already discussed, it's acromegaly, deep sonorous voices. Question number 8. A 28-year-old female singer with no comorbidities presented with inability to sing high notes during the few days prior to her menstrual cycles. She also complained of low mood, abdominal bloating during those days. What do you think her condition is? Psychogenic dysphonia, spasmodic dysphonia, recurrent laryngitis, or dysphonia premenstrualis? So the answer to this question is D, dysphonia premenstrualis. So it is a part of the premenstrual syndrome, and this happens during 4 to 5 days prior to the cycle, and they can have a reduced range and loss of certain hormones. So especially to sing the higher notes, they will have a problem, and mostly singers complain about these problems. And it also occurs due to the increased progesterone levels, which occurs after the ovulation. So the question number 9 is a related question to this. So which of the following is caused by the effect of progesterone on the vocal cords? A, lengthening of the vocal cords, increased secretion of laryngeal glands, dryness and reduced tonicity of vocal cords, atrophy of the laryngeal muscles. So this is an article from IJEM 2016 by Dr. Hari Kumar. So as you can see in this table, various hormones through various stages of their lives can affect the voice. So our question was about progesterone. So progesterone causes dry vocal cords and reduced tonicity of the laryngeal muscles. And this is responsible for that dysphonia premenstrualis. And the answer is C, dryness and reduced tonicity of the vocal cords. So last question, that is question number 10. Menopause in women can lead to A, decreased pitch of the voice, B, increased pitch of the voice, C, no change, D, either of the above. So the answer is A, decreased pitch of the voice. So menopause leads to reduced estrogen levels and a relative increase in the androgen levels. So this also, the reduced estrogen levels can lead to atrophy of the vocal muscles. So overall, they will have a reduction in the pitch of the voice. And the answer is A, that is decreased pitch of the voice. So I've put up all the answers in the slide, so you can see. So we had 5 responses from the audience, and P.S. Gargari has answered all the questions correctly. So he gets 10 points and has scored the highest. Ram Barure and Afra Fatima have scored 8 points each, and Dr. Kaushal has scored 7 points, and Vishwanath has scored 5 points. So we have the winner, that is PS Dargari. And the last
we must cheer.
audience.
Yeah, please, big applause to the winner, one who has scored full marks.
So I think, so congratulations to all the participants as well as Dr. PS for scoring it 10 out of 10. And Dr. Kalpana, Dr. Nandini, Dr. Spurti, a very cordial thank you from Endocrinology Society of India. Or final comments on the topic.
Pleasure. So it has been a women's team. I think the audience must have enjoyed. So as I earlier also said, you must pursue this as a super specialization, whether medical or surgical, and read more and more about it, see more and more cases, try and make recordings. You know, for all the junior trainees, I would say, like we have a lot of laryngoscopic pictures. We've made albums, you know, with different kinds of vocal cord lesions and palsies, etc. So please do that from now on, so that you will have an excellent album of voice disorders, and then go and interact with other specialties, and then learn further treatment modalities and newer treatment modalities. Even engage with the speech pathologist. Believe it or not, even they will give you a lot of tips. So every laryngectomy patient or otherwise, pre and post, all dysphonia cases, we do involve the speech pathologist, and you'll be surprised that we have a detailed questionnaire, and then even children with cleft palate. I do not know if it was mentioned in the slides. Cleft palate, was it mentioned? Because speech is again very, very important in such, even at such an age, even in children, because whether the speech therapy is to be done or not after cleft palate surgery, and how much is it delayed, because there are a lot of young adults who come with for cleft palate surgery, and that's when recovering the voice is very difficult. They may not get a normal voice. So there are so many, as we discussed, starting from the sinuses to the palate, to the muscles, whether extralaryngeal or intralaryngeal, nerves, whether it is recurrent laryngeal nerve or superior laryngeal. So everything, even lungs and trachea, because after all, pressure is built up from below. The subglottic pressures have to be adequate. So the apparatus is a long, lengthy one, starting, as I said, from above to below. The upper and lower airway, both are involved, both are important. So if there is a palsy that you see, there could be a lower respiratory cause. There could be something near the aorta. So keep your eyes open and get your diagnosis correct. And that's how it's. So there are various, so what the mind knows, the eyes see. So you have to know the causes and go systematically. This is my advice to all the younger adults.
Dr. Nandini, thank you very much for your final comments.
Thank you for this opportunity. I agree with Dr. Kalpana. As endocrinologists, we often don't pay so much of attention. So it was really refreshing to have this topic for discussion today. And what I feel is that we should collaborate more with our colleagues, with our ENT friends and voice therapists especially. I think they have so much more to offer, and we should definitely pursue this as an interest. Thank you so much, Dr.
Thank you, Dr. Spurti. The questions were excellent. It was very interesting. And I would again like to thank Dr. Kalpana, Dr. Spurti, and Dr. Nandini for an excellent session on a very, very interesting and a very refreshing topic. So we look forward again to meet all the delegates next Sunday at 4 p.m. on a different topic. So we have been having these webinars for almost last 6 to 8 months. I would like to thank Dr. Ganapati, Dr. Sujay, Dr. Kalra, Dr. Harikumar, and also Dr. Sheila Sheikh for being part of this. They are the organizing team behind all this. And again, a very cordial thank you from Endocrine Society of India to all the delegates who have joined for this session.